Thanks, Delphine, for the kind introduction. And thanks, Lena, for the invitation. Nice to see Martin. I think the last time I presented here was 2017. I don't think most people's faces are not familiar. But as you heard, this is the primary focus of our group's work, is looking at the connection between bipolar disorder and heart disease. And Delphine, I totally agree with you that our hope is, and we're planning collaborations to extend that scope to serious mental illness in general, because it's not, what I'm talking about today is a paradigm. I think that bipolar disorder is particularly strongly associated with heart disease, but I don't think it's different for schizophrenia. On average, probably more so than for unipolar depression or anxiety. But at some level, all of the patients that you would see at an institution such as this or at our institution are at greater risk for heart disease. And so what I'm hoping to talk about today is not just their future heart disease risk, which is important for them, of course, but also the relevance that has to here and now mental health, neurocognition, and brain health, which is something that I think is relatively underestimated or underappreciated.
Sorry, you're a little bit taller than me.
So these are the objectives: to identify factors that underlie the elevated cardiovascular risk, to look at the relevance of various vascular metrics to brain structure and function, and to consider what we can gain in terms of mental health systems of care, understandings of pathophysiology, conceptualizations of the illness by integrating cardiovascular health within that. Just to establish a little bit of the epidemiology, this is a study that we published almost 10 years ago now, looking at a large general population sample from the US. So the advantage of this is, first of all, you have 40,000 people, and that allows you to control for a whole bunch of things. So the analyses that I'm going to talk about controlled for demographic characteristics, blood pressure, body mass index, nutrition, alcohol use, et cetera, et cetera. The other thing is that the unfortunate reality for most people with bipolar disorder is that they're not pharmacologically treated for bipolar disorder. Either they have no pharmacological treatment or they have antidepressant treatment. So that's probably not the case in the Douglas, but in Quebec in general and Canada in general, that is the case. And so because of that, the vast majority of participants in this study did not have any medication, which enables us to look at the heart bipolar connection with minimization of confounding factors. So as you can see here, the age of new onset heart disease among people with bipolar 1 disorder was fully 17 years earlier than those without mood disorders. And those people without mood disorders, they could have addictions, they could have anxiety disorders, they just couldn't have major depression or bipolar disorder. So I think this slide depicts how I would view the association, which is to say it's very strong in bipolar disorder. It's also significant and strong in depression, on average, not as much, but still meaningful. And among people that have severe or recurrent depression, depression with psychosis, probably equivalent. But if this difference in recognized heart disease happened 17 years earlier, then the question is, when did the process begin going awry? And I'm going to present information that would suggest that this is already evident, at least by adolescence. So you may think, okay, how much of this is relating to the pandemic context, social media, obesity, living in lived spaces where we can't have exercise, et cetera, et cetera. But these associations were observed over 100 years ago when we didn't have any treatments, let alone contemporary treatments. So Emil Kraepelin, who was not perfect as an individual, but as an observer of the manifestations of bipolar disorder and course of illness, I think he was the top. And he had no conceptual model or theories, and so he just looked at 1,000 patients over time and wrote down what he saw. And almost all of the findings that he observed have been replicated in contemporary studies. And what he saw was not at all infrequently, and in comparative youth, arteriosclerosis is present. So my point is that this is not just a manifestation of modern society. So that's 100 years ago. What about currently? I recently participated through on Reddit, CREST-PD, which is a patient advocacy knowledge translation team led by Erin McCalloch at UBC. Leads this on Reddit on World Bipolar Day, March 30th. Every year, she convenes like 20, 30 experts by lived experience, by professional experience of bipolar disorder. People can ask whatever question they want. It's called Ask Me Anything. And this is one of the questions that got directed towards me. So I'll just read the whole thing out. Hi there, I'm 52 with bipolar disorder type 2. I don't drink, smoke, do drugs, and I was or am in good shape. No history of heart disease in my family. And last April, I had a massive heart attack, which has led to heart failure. Turns out I'd started developing severe coronary artery disease at some point in the previous decade. I've read up on the correlation between bipolar and heart disease. I assumed that lifestyle factors were the driving force. However, that doesn't seem to be the case in my situation. essentially what's the current thinking about bipolar disorder and heart disease. And so I put this up because just to bring it to real life, it's not a person that I know. I don't even know their name. They're not my patient. This is just an individual who was really taken aback by, I've got all my check marks in. I'm not using substances. I'm leading a healthy lifestyle. Presumably don't even have cardiovascular risk factors. And here I had this life-altering heart attack. So I think that part of what I'm going to talk about today is the factors that drive heart disease that are above and beyond what we would call the usual suspects. Before getting more into the vascular topic, I just wanted to make an emphasis. I know this is a youth mental health center of excellence. We have a center for youth bipolar disorder. And so sometimes people say, well, why do you have to specifically focus on youth? So I don't think this audience needs to know why, but you already do. But I'll just emphasize the fact that one third to 2/3 of adults with bipolar disorder have early onset, defined as either before 18 or before 20, depending on the study. The 1/3 is in general population samples, and the 2/3 would be in clinical samples such as this one. And in those people who are adults who tell you looking backwards that their illness started when they were kids or teens, whatever way you want to use to define the greater severity, greater persistence, greater perniciousness of bipolar disorder, it's all elevated. And it's elevated in community studies and it's elevated in clinical studies. This data started out as cross-sectional retrospective, but then even if you look at prospective studies, you see that people who, let's say they come into, there was a clinical trial network called STEP-BD. And in STEP-BD, they recruited thousands of people with bipolar disorder. And as part of the question, they asked age of onset, and then they followed them over 3 years. And they found that those people that said they had early onset bipolar, it's not just that they tell you that their illness has been worse, which could be biased, right, by their state of mind, by their mood state. If you follow them prospectively, they continue to manifest more severe versions of bipolar disorder. So basically, this is a real thing, that early onset bipolar disorder is not just worse when you're young, but it seems to, at least in the current generation of middle-aged adults, continue causing problems. This is a slide that I like to present for a couple of reasons. One is it was published by Dr. Nikki Kozloff, who did this during her residency. So I'm a big fan of people getting into research during residency and trying to answer questions or address issues that they're seeing clinically and try to learn something that isn't known. So Nikki published this paper based on the Canadian Community Health Survey. And the data are a little bit old, but I think that they likely still hold true. I don't think our health, at least locally in Toronto, our health systems have not changed markedly. And what you see here is that even though it's a general population sample, and if you alert your focus to the 15 to 18-year-old column, first of all, there's a propensity for women to have this more often than for men in adolescence. It's not well understood, but it's seen in clinical and epidemiologic studies. I'll just put that comment to the side, but I think that it's relevant to today's discussion. You see high rates of anxiety, substance use disorder, suicidality, and so you would expect for sure this is a treatment-seeking sample, but actually less than 50% reported having any form of mental health treatment whatsoever. I'm not talking about lithium. I'm talking about talking to a counselor, talking to your family doctor. And so the question is, how can such a reality exist that's reflected in this slide, that people have 50% have suicidality, multi-comorbidity, and half of them haven't had any sort of treatment? So the study wasn't designed to address the reasons, but I posit that even in 2024, stigma and shame and different approaches that we have to mental illnesses versus physical have to be at least part of this. And part of the lens through which I look at the heart bipolar connection is that this can add some value in terms of demonstrating that bipolar is not just in your mind, it's not just even in your brain, but it's in you as an individual, both brain and body. Starting about 10 years ago, I read a paper based on youth with conditions that confer increased risk for heart disease and accelerated atherosclerosis. And I thought, this is fascinating. Since those kids don't have heart disease, how did they determine that those conditions, so example, rheumatoid arthritis in kids, or kids that have resolved Kawasaki's disease, these sorts of conditions. So how do they define them as being at risk for future heart disease? And I looked at the benchmarks and I thought, it's funny that depression and bipolar disorder or schizophrenia aren't in here, because I'm pretty sure there's data there that show already at the time. In any case, it gave us an opportunity to make this pitch to the American Heart Association that in fact, depression and bipolar also met that same benchmark that they had set. And that while they weren't about to redo the paper, that we could do a new scientific statement that established that depression and bipolar in youth, like those other conditions, also warrants more attention and more intervention. So here's the clinical implications. There's two tiers. Tier 1 is high risk, and these are things that are self-evident. Like there's no surprise that someone with diabetes is at risk for heart disease, or that someone that's had a heart transplant is at risk for heart disease. I don't think we would be surprised. You may not know that inflammatory illness in youth also drives heart disease risk as it does in adults, or that people that have recovered, that are in treatment for HIV, have had nephrotic syndrome. These are not super common. So if you look at these moderate risk conditions, altogether, about 1 in 200 youth will have one of those other conditions. But if you put major depression and bipolar disorder together, about 1 in 10 will have one of those conditions by the time they finish adolescence. And so if you're interested in preventing excessive heart disease that's driven by secondary medical conditions, it would really benefit you to pay attention to youth with mood disorders. So, I mean, that was good because I think it brought this heart bipolar connection to the mainstream. I say heart bipolar, it's also major depression. Before switching into the second part of my presentation, which is going to start looking at physiology, I wanted to underscore some questions that people may have in their mind. And it would not be uncommon for people to be wondering how much of this is driven by meds, how much of this is driven by traditional cardiovascular risk factors. Lots of our patients have obesity and high blood pressure. So I just wanted to take a moment to emphasize why I think that those are not the sole explanations. So first of all, you see that there's biological perturbations in bipolar disorder, and they may share underlying causes with heart disease and with bipolar disorder. Inflammation is probably the one that you're most familiar with. We're really interested in endothelial function, the functioning of the inner lining of blood vessels. There's behavior and environment. So these things are true. People with bipolar disorder have sleep disturbance. They use substances more often. It's very difficult to quit smoking once you've started smoking if you have bipolar disorder. We know that exercise rates and nutrition are suboptimal. And then you have medications. And what we know for sure is that they are associated with increased risk of cardiovascular risk factors, but it is not established at this point that they're associated with increased rates of heart disease. I still put it up here because I think obviously we're trying to minimize the negative impact of the medications we use. But I also am not overly apologetic about it because I think that our patients require these medications. You know, if lithium causes a little bit of weight gain, it's a reality of lithium. So I think that this one, in my view, has been drawn the most attention, even though as the driver, I think that the data is not really there to support it. So as I was saying, I think that meds are an issue. They may increase cardiovascular risk factors, but we know that the heart bipolar connection is over and above traditional cardiovascular risk factors. So there has to be something else that's explaining that difference. The second thing is that, as you saw from Dr. Kraepelin, and there's also others, this goes back to Egyptian times when mood disorders were characterized as diseases of the heart rather than of the brain. This link has been established well before we had contemporary medications. And then the third part is, like I mentioned in my opening slide, unfortunately, most people with bipolar disorder actually aren't on the medicines they're supposed to be on. So it had provided a natural experiment. All of this to say that I think that there is something more directly related, I don't want to say causal, but more directly related to this heart bipolar link than just it being the added effect of stress and sleep and meds. So you may be wondering, of course, none of us want our patients to have early or excessive heart disease, but what does this have to do at a mental health hospital? And similar to how I mentioned that early onset bipolar is more complex than later onset or typical onset bipolar disorder, we also know from multiple studies, both in clinical samples and population samples, that if you have a cardiovascular risk factor or more than one cardiovascular risk factor, those are associated with more severe manifestations of bipolar disorder, more time with symptoms, more addictions, more suicide attempts. And I put some asterisks on the ones that are replicated in adults and youth. And the suicide attempts one is really interesting from my perspective, because just taking the simple association between a high body mass index and suicide attempts, obviously that's an association and we don't know anything about mechanism. But the fact that it's been shown in youth and adults, in each age group, in community untreated samples and in clinical samples tells us this is something relevant. This is something that has the potential to give us another target in terms of optimizing physical health to affect psychiatric outcomes, as well as mitigate the risk of physical health outcomes. So for the next section of this presentation, I'm going to give a series of snapshots. And I won't go into a huge amount of detail on each one, but the overall goal of this is to get you thinking about ways in which this connection could be manifesting, both biologically and in terms of its implications. So this study is led by Dr. Cody Kennedy, who's an early career scientist with our group, who's currently meeting with cardiologists at MUHC. And Cody did this first paper for his thesis, very, very straightforward paper. Simple question: do levels of cholesterol in your blood relate to your brain structure? Dozens of studies on this in older adults. In dementia, it's very clear that optimizing cardiovascular risk helps prevent dementia, helps prevent worse progression of dementia. But when he wrote this paper, he wrote the introduction and I read it and I said, okay, like where are the papers in youth on lipids and brain? He goes, there aren't any. I said, okay, like there's got to be one. I mean, I'm not talking about bipolar disorder. I'm just talking about youth. Like, what about youth with severe obesity? What about youth with diabetes? There hadn't been, not a single paper. So I think that there's stigma against bipolar, but there is also a weird stigma. I mean, I guess all stigma is kind of weird, but a weird stigma towards youth not being like fully biological entities. Like we don't even think about the fact that cholesterol may reflect on their brain. At least I was surprised. I'm not surprised that there's not been a bipolar youth lipids brain study. I think that makes sense, but that in any youth population, it hasn't happened. So I think in this area, we're facing those two barriers of preconceived notions about mental illness not being 100% real, and preconceived notions about young people not being 100% fully formed people, which I think the data show you otherwise. So in orange, what you see is higher levels of lipids, in this case, LDL, are associated with lower hippocampal volume. And whether it was a region of interest analysis or a whole brain analysis, whether we looked at volume or thickness, in every instance, higher lipids were associated with lower brain structures in youth with bipolar disorder to a significantly greater extent than in healthy youth. So you see that in healthy youth, there's like a marginal positive association, which we don't know what to make of because there isn't precedent for it. But I would say that if we bring those kids back in 20 or 30 years, they'll look just like the youth with bipolar, that eventually, for all of us, higher cholesterol on average will be associated with lower brain structures. And then you could say, okay, well, the relevance to brain in terms of its function. This is work that was done by Dr. Melanie Nyberg, who was a PhD student with us several years ago. Also a relatively straightforward study. I say straightforward because these are studies that had been done in numerous middle-age and geriatric samples. There's conferences on vascular cognition associations. It's just really neglected in psychiatry and in youth. And as you can see, higher levels of triglycerides were associated with lower cognitive flexibility on computer-based paradigm from Cantab in youth with bipolar disorder, whereas in healthy youth, there wasn't an association. So these are small studies, these are initial studies, they have to be replicated, but they are pointing in the same direction. So then the question is, I mentioned to you that traditional cardiovascular risk factors are not the whole story. If they were, it wouldn't be, I think, that interesting. What if we look at something more close to mechanism? So looking at genetic liability towards coronary artery disease. So you're probably familiar with genome-wide association studies. Early phase genetic studies looked at like a single marker that would have a large association, was very difficult to replicate. And now the field has moved, I think, in the opposite direction, which is a whole batch of small markers that are reliably associated with a condition in studies of tens of thousands or hundreds of thousands of adults. So the studies for the genome-wide association studies for heart disease, as you can imagine, are very large. And so these are well-established polygenic risk scores. And we asked the question, if you took this polygenic risk score, so this genetic index of risk for heart disease, based on adults in the general population, and examined it in relation to brain structure in teenagers, what would we see? And so what we found was in the overall sample, the total sample is about 100, roughly evenly distributed between bipolar disorder and healthy controls. You see that greater polygenic risk scores were associated with smaller structural indices. I won't go into each and every region for the purpose of this slide. Rather, what I'd like to show you is two things. One is the association was always negative. So whether it was area, surface area, thickness, or volume, whatever the region, whether it was in the whole group, the bipolar disorder group, or the healthy control group, it was all towards the direction that greater genetic liability for heart disease was lower regional brain structures. And the second thing is that, these were based on whole brain analyses, which means, you examine multiple regions across the brain without a hypothesis, then correct yourself statistically for having done that and see what survives the stringency of that correction. And as you can see, there was 5 regions that came out in bipolar disorder. We're not doing a numerical comparison here, but it's interesting, right? So knowing what we do about the differential susceptibility that teens with bipolar disorder have for cardiovascular risk in terms of their brain structure and cognition, this is interesting. And of note, I mentioned earlier that teens with bipolar disorder are more likely, it's more common in females. It's also a well-established fact that the greater risk of heart disease in bipolar disorder affects females more than males. So the difference between a woman with bipolar disorder and a woman without is larger for cardiovascular mortality than a man with bipolar disorder versus without. So it's interesting to me that these are youth that are 20, hopefully more than that, years before they're going to have heart disease. And already you're seeing that this association is stronger in females than in males. And this work is led by Nidhi Kulkarni, who's currently a fourth-year PhD student working with us. Okay, so shifting from directly looking at the brain or cognition, I'm going to talk about some other blood vessel systems that you can look at. So this picture, which is pretty, looks like a planet of some sort, is actually a fundus photograph. So if you've gone to the eye doctor, they will take a photo like this. And as you can see, there's different types of blood vessels. I know you guys are a little bit far away from the screen, but you can probably see that there's wider, darker vessels and narrower, lighter vessels. And the wider, darker ones are venules, and the narrower ones that are lighter, they're lighter because their walls are thicker. And so you have like a bit of a space in the middle where there isn't an arteriolar wall. But essentially, with a couple of hours of training, anybody in this room would be able to distinguish an arteriole from a venule, would be able to place the grid that we use on this image, and would be able to calculate calibers of these different vessels. And while the data in bipolar disorder is quite limited, these metrics, as simple as they are, so it's a simple photograph, literally with a digital camera, and you overlay a grid, and then you come up with the average width of the vessels of your veins, tiny veins, average width of your arterioles, you look at the ratio, and those have been associated with predicting future stroke, predicting future heart attack, predicting future dementia, over and above traditional cardiovascular risk factors. And this is Megan Mio, who's did this work for her PhD and is continuing it in a transdiagnostic sample currently as a postdoc. Why do we look at retinal vessels? Because the retina is part of the central nervous system, and the biological properties, the genesis, the development of these vessels, they're all almost exactly the same in the retina as they are in the brain. So this is the closest we can come to taking a picture of a brain blood vessel. So in one of Megan's PhD thesis papers, what she looked at was, what is the relationship between your retinal eye vessel structure and your brain blood flow? And first of all, we predicted that youth with bipolar disorder would have worse vascular metrics based on what was considered bad in the prior literature. So what's considered healthy and good is to have larger arterioles and smaller venules, essentially more supply, and then on the way out, less. And we actually found the opposite, that the teens with bipolar disorder had larger, healthier, if you will, arterioles than the healthy control teens. So that was the exact opposite direction of what we predicted. And one of our speculations is that this is compensatory, that somehow, because we'd had prior findings with cerebral blood flow showing that healthy teens with bipolar disorder who are euthymic actually have abnormally elevated blood flow, which was again opposite to what we predicted. We see these two things as potentially going together. So can we examine it directly? So the idea is you have a brain that has high energy requirements. You have bipolar disorder, an illness characterized by deficits in mitochondrial function and energy utilization. So it's essentially a fuel inefficient, high fuel demand organ. And potentially what we're seeing here is that in young people, unlike in older people, they're still in this adaptive phase of just trying to overcompensate for that by just maximal vasodilation of their eye vessels, maximal dilation of their brain vessels to try to meet this hungry need of the comparatively inefficient organ. And what we found was that these two did line up. So the larger your arterioles in your eye, the greater your regional cerebral blood flow. And as you can see, the regions that are depicted in this image, they're all statistically significant as regions, but they're not discrete in terms of their localization. It looks like they're scattered across the brain. So while there may be some regions of the brain that are especially prone to differences in blood flow or vascular risk, just mentioning the fact that we see it as more of a whole brain issue, maybe with slight variations in terms of how much it's important in one area versus another. So we've gone from brain to eye, and now going down the chain looking at heart. There's really not been a lot of cardiac MRI studies. Most of those studies have occurred in people that have major congenital heart disease. So you're born, you have potentially, major vessels of your heart are fixed in the wrong spot. You have to have open heart surgery, and those people need like lifelong follow-up. So a lot of the time, MRI can be used to help either guide surgery or to guide monitoring of the outcome of surgery, et cetera, et cetera. No surprise that that's where some of the MRI studies are, but in terms of youth with psychiatric illness, or even in healthy youth, not so much. So this is a study that looked at two things. One was traditional metrics of cardiac structure and function. So if folks in the room themselves have hearts, their parents have hearts, their grandparents have hearts, and some people, they have heart failure, they have to go and get assessed, and they have great metrics. They can tell you each time your heart beat, what is the ejection fraction, how much of it is going forward, how big are your different chambers of your heart expanding to when they're full versus when they're contracted. These are all well-established clinical metrics that would inform interventions if you have heart failure or pre-heart failure, as was the case for that 52-year-old person that made their comment. So what you can see here just from the p-values along the right side was, if you look at the volume of the heart, if you look at the ejection fraction, its overall structure, its overall function, there's no difference between teens with bipolar disorder and healthy teens. So if I was to guess one way or the other, I would have thought that maybe there's a marginal difference, and maybe if we had 1,000 people, there would be a marginal difference, although numerically it doesn't look to be of substantial effect size. But there's another way you can look at the function of the heart, and that is to look at not only just these big picture numbers, but can you quantify the reactivity of the tiny vessels that feed the muscle of the heart? So you have this heart and has coronary arteries on the outside that bring blood to it, but that blood has to get to the heart muscle for it to pump. And it's the challenges getting that blood to the muscle of the heart that are part of what causes heart failure. And it can be quantified using fMRI, similar to what we see in the brain, based on changes in blood oxygenation signal. And so what we did was, this was work that we didn't invent. In fact, rather we replicated it. So this work had been done by Matthias Friedrich and colleagues at MUHC, looking at people who have had a heart attack or who have had coronary artery bypass surgery, trying to see who did it work for better, who's doing well, and trying to add this metric on top of usual clinical metrics to see, can it help you with precision? Can it help you inform your decision-making? So the task is the following. You go into the MRI scanner, and we have people breathe comfortably, and we obtain a resting state bold fMRI signal in the heart. Then we have them hyperventilate for a minute. So that means that over the course of a minute, you're going to have 32 breaths, which is much faster than we would comfortably breathe. You hyperventilate for a minute, you exhale fully, and that's when your breath hold starts. So you see the little dip at the 10 seconds, that's the post hyperventilation, and that's our real kind of baseline point of interest. This is the T2 MRI signal intensity after you've hyperventilated and exhaled, and now the clock starts, and the task is, can you hold your breath as long as you can? And we need people to get to 30 seconds for this to be valid, but most of our participants could get to 40 seconds. We were chatting earlier. I'm not sure how much this will extend to people 30 years into their course of illness in their 50s, but in our sample, average age 17 years old, high adherence with this protocol. And there's an elasticized band that goes around the rib cage that would tell you if there's a breath excursion. So we know, we can verify whether or not they adhered with the task. So what you can see is that overall, there was an increase in the bold signal. So as you hold your breath, carbon dioxide builds up in your blood, and that's a potent vasodilator in your heart and in your brain, not so much in other places. So that vasodilation can be quantified by this change in bold signal. And as you can see, there was a significant increase in the bipolar disorder group and in the healthy control group, but it was blunted in the bipolar disorder group, as is depicted in red. And that was significant by the 30-second time point and continuing on. So taking this together, this analysis, by the way, controls for age, sex, and body mass index, and other sensitivity analyses didn't meaningfully modify this finding. So to summarize, you have a teenager in the heart scanner, controlling for most cardiovascular risk factors. In the absence of any gross clinical problem with their heart, the teens with bipolar disorder are already manifesting a subclinical deficit in their ability to respond to this stress test for the heart, this breath hold. And so the question is, okay, we know in the adults this predicts heart attacks, but does it really mean something in these kids? So here too, we said, okay, well, we have these polygenic risk scores for heart disease. Why don't we look at it in relation to this measure that we have that we think is important? And as you can see, both for myocardial infarction and for coronary artery disease, the higher your genetic risk for those conditions, the worse your coronary microvascular reactivity is what we call it. So we think that although we're not doing arteriography on these youth, we're not looking at atherosclerosis, they clearly don't have heart disease, but triangulating all these things, we think that this is a very relevant metric for a population that's at risk for future heart disease as an early index that is definitely subclinical. This is not something that a family doctor would order as a test. So bringing it all together, we've talked about the fact that vessels are relevant to bipolar disorder in the brain, in the eye, in the heart. I didn't present work on the fingertip, but we also look at measures on the fingertip, and those seem to vary according to mood states. And so over the next few years, what we're hoping to do is bring these all together in a construct that's whole body, and ask the question of, if you look at whole body vascular metrics, feeding in all of these measures, structural and functional, can we pull out a subgroup of youth with bipolar disorder who are like extra high risk? Because this would be the group where we really want to intervene with early. Maybe for the medium risk ones, we're trying to modify their lifestyle, which we try to anyway. But for the other ones that are ultra high risk, they have bipolar, but they also seem to have this strong interrelationship between vessels throughout the body. This may be a subgroup that's worthy of investigation and intervention in a different category than the rest. So I'll give you a break from the cardiac physiology and come back to, I think, day-to-day life, which is what can we do about it? And some of the things are fancy, I think, in terms of more refined assessment of vascular risk, but some of them are not fancy, and they're called exercise. And that's the main one that we focused on. So just a comment to say that there's a lot of, I think, excitement about certain diets right now. And I think that that's great. Anything that helps people with major mental illness, anything that helps them live longer and is healthy. Our focus has been on physical activity, and specifically cardiorespiratory or aerobic exercise, because in my view, it has multiple potential benefits unrelated to weight loss. So in terms of, we'll talk about them. So here's teens with bipolar disorder and healthy control teens, looking at their whether they meet the benchmark recommended from the American Academy of Pediatrics as it relates to working out, so moderate to vigorous physical activity, this is cardio, working in incidental physical activity, taking the steps, walking, gardening, ironing, whatever you do, and sedentary, which is trying to limit the amount of time that you are seated. As you can see, in general, youth don't meet these benchmarks, but the one place where the youth with bipolar disorder lagged as compared to healthy youth was moderate to vigorous physical activity. So precisely the type of exercise that we think would be most likely to benefit their brain, to benefit their heart disease risk, is the one that they're really avoiding. So in this study, based on a clinical treatment seeking sample that reached us, 1 out of 20 of our patients told us they met the minimum threshold. I think we know from any type of self-report, it's probably half that at best. And that's meeting the minimum threshold, where in reality, this is a population that would probably benefit from an above minimum threshold. So I would say that this slide says what we already know, which is that we have a real challenge in terms of helping our patients reach the point of regularly physically exercising and developing, in turn, cardiorespiratory fitness. So from a prior neuroimaging study that we had that I'm not going to talk about in much detail today, but we essentially had teens with bipolar and healthy teens come in. They had an hour in the scanner doing various tasks and measurements of cerebral blood flow. They were then taken to a different part of the hospital where they did 30 minutes on a recumbent ergonomic cycle. So 5 minutes of warm up to reach 70% of their aerobic max based on their heart rate and age, and then 5 minutes of cool down. So just anecdotally, one of the things that struck me about this study was that for a lot of my patients that enrolled in this study, this was the first time they'd done 30 minutes of cardio in high school. So that was like really daunting to me, because like I had someone come out and they were excited about the fact that they'd done it because they didn't know they could do it. And I was like, well, what do you mean? Like how often, when was the last time you did it? And they're like, grade 7, grade 8. So that was really like, I knew that they don't exercise commonly, but that was sobering. So they do this exercise session, then they go back to the scanner and repeat the scans that they did. So we looked at pre-post on the same day in the same person. Because they're on an ergonomic cycle, we were able to look at a proxy measure of their cardiorespiratory fitness. So this isn't the setup where you're on a elliptical with a mask and the whole VO2 max, but it has been significantly associated with that gold standard. So you're looking essentially at your heart rate relative to how much power is coming out of your feet relative to your age. And this measurement, although you can see there's a lot of overlap in terms of this measurement of cardiorespiratory fitness, you can see that the teens with bipolar in red have lower cardiorespiratory fitness than the healthy control teens. Among the teens with bipolar, the lower their cardiorespiratory fitness, the greater their depression. This was a cross-sectional study on one given day, so we don't know what's the direction of the association. Is it that people with bad cardiorespiratory fitness have a greater likelihood to develop depression? Is it that depression limits your ability to exercise and so you get less fit? I think that the data would suggest that it goes in both directions. But in any case, again, a treatment target. So these are youth that are treated. This isn't a population sample. This is the kids in our clinic with us doing the best that we can do, and they still have depression with meds, with therapy. And so here you see aerobic fitness is associated with greater depression. I'm not sure what the facilities are like here in terms of how many units have a physical therapist that actually gets people on a bike or going for brisk walks. At least locally in Toronto, it's very uncommon. In fact, when we hired a part-time person as a registered kinesiologist, it was the first time CAMH had hired one to anyone's knowledge. So I think we can't overstate how disconnected exercise interventions are from the populations that we treat. This is no disservice to recreation therapists who are doing their best and to limitations we have in our facilities, but I haven't been on your units. Maybe there's like an old exercise bike that holds people's jackets. I don't want to be facetious. Is it different here? Okay, so there's a swimming pool. So my hypothesis will be that it's tough to get people to go. I think it's kudos to you guys for having that facility. But in any case, the point made here that this doesn't necessarily have to cost a lot of money. This is widely accessible and maybe a missed opportunity. As part of the fact that it was an imaging study, we were able to look at changes in cerebral blood flow. So what you see in this slide is areas where there were significant changes in blood flow before versus after in teens with bipolar disorder. So our hypothesis going in was the teens with bipolar would have low blood flow in their brain, that exercise would elevate it, and that this would happen more so in teens with bipolar versus healthy teens. And what we saw was the opposite. On average, they had elevated regional cerebral blood flow. As I speculated, I think that's related to energy metabolism. But post-exercise, there was no significant difference. So for what it's worth, in this sample of 50 against 50, there was pre-exercise differences in favor of abnormally elevated blood flow. Post-exercise, no differences. And what you see in the scatter plot is the association between reductions in frontal cerebral blood flow in teens with bipolar disorder and the subjective experience of exhaustion. So if I told you that there was an abnormality in the brain, that a single session of exercise normalized it, do you think it had a good effect on mood or a bad effect on mood or subjective well-being? I would say you'd feel better. They felt worse. So to me, this is an example of a slide that I sometimes will pull up, even clinically, because if you've talked with people about exercise that have major mental illness, you likely have heard the fact that people will sometimes say, my relatives tell me it makes them feel good. My friends tell me it makes them feel good. It actually makes me feel worse. And for the first few years that I would hear that, I would think that that's maybe language people use to explain why they're not exercising. It didn't occur to me that had a physiologic basis. And then this slide came back and I felt a little bit embarrassed about myself because this shows me that those youth that have this physiologic difference that most normalizes feel like they told us right after the exercise that they felt crappy, and then they went and got their brain scan. Like there's no way one influenced the other. So the metaphor that I use for this is when someone goes to physio for their shoulder or for their hip or for whatever, they're not going in thinking they're going to feel better today. They're going in expecting to feel better, sore today, uncomfortable today, and the goal of feeling better in 2 weeks or in a month from now. And that's the metaphor that I use, is to say that this is maybe normal for a young person either with bipolar or who doesn't exercise, that I think with repeated sessions, this is going to get better. And that really what's hurting, which we usually avoid, seems to be like it's doing something good for your brain. So don't avoid it. So in terms of next steps, we're looking towards intervention. So to summarize the literature on exercise, we know there's low rates of aerobic exercise in teens with bipolar disorder, lots of benefits for their heart, for their brain, emotionally. The benefits are within reach. So I completely disengage this conversation from weight loss. Like I do not talk about exercise in relation to weight loss. Everybody knows what they have to do in terms of caloric exercise expenditure balance. They don't need to hear it from me. I emphasize the fact that this could benefit their mental health, their cognitive sharpness, their future heart disease risk, even if they don't lose a pound, because otherwise you're just going to kind of disengage patients. I don't know if you guys have the same experience, at least locally for me. A lot of the time you have parents asking you to tell the kids exercise more, eat less, and that sort of thing. And I don't think it's a fruitful endeavor. And I also emphasize the fact that the greatest benefits come to people who are starting off in the worst shape. So that kid that I told you about who hadn't done exercise in 5 years, even a modest increase in aerobic fitness is going to have a meaningful effect on if they can sustain it, on their future heart disease risk. Whereas if you run 5K a couple times a week and you go to 10K, you can't move that much farther up the pyramid. But our patients that are doing 0, they have a ton to gain from even modest improvements in their cardiorespiratory fitness. This does not, we were joking about Mick Jagger and the fact that he's 80 years old and can dance on stage for hours, like extreme outlier, but you don't have to be an extreme outlier to generate these benefits. So we finished a study funded by Brain Canada, where this was essentially a motivation enhancement intervention. The idea was, people sometimes prescribe exercise, and I thought, well, my patient knows I'm advising them to exercise. My prescription can't be like given in anywhere, and you're not going to get anything back for it. So it just seems like, to me, it seems silly. So we focus on motivation enhancement, essentially trying to help people resolve their ambivalence about exercise. Some people worry about it's going to make them manic. Some people worry that it's not going to affect their weight. And so then what's the point, et cetera, et cetera. So the blue parts are the parts that were for everybody, part of the intervention. Psychoeducation, the heart bipolar link, the cardiorespiratory fitness link, aside from weight, the motivation enhancement sessions with a social worker who is depicted here, weekly phone calls to check in on mutually generated goals, objective aerobic fitness training. So you can't just ask people what they did, and even Fitbit is limited. So we had people do 2 types of tests. One was a modified Canadian aerobic fitness test. So that's looking at 2 aerobic step risers, and the youth hated that one. And the reason is that it works really quickly. So you essentially have a beat to music that's going, and with each beat you have to step up, and then that beat goes faster and faster with each stage. And within about 15 minutes, you're like ready to be done. So it does what it's supposed to do. And then the other one is a modified Bruce protocol, which is like the gold standard aerobic test, but without the whole physiologic setup of oxygen and CO2 monitoring. So you go on an elliptical that has increasing pace and increasing steepness. So we have objective fitness testing. And then the green parts were a la carte. So we had, as we were planning this study, debates within our team. What are the youth going to want? And so some people said we got to have their family involved. If they don't have their family involved, their milieu won't change. They won't sustain their behavior. Other people said it's got to be youth focused. Nobody wants to be with their mom and dad exercising. Other people said they need exercise coaching in addition to what they could have in their daily life otherwise. So we gave them all of the options, and they could choose whatever they wanted. The take-home message from this slide was that all of the youth completed 90% plus of all of these measures, including the aerobic fitness testing. So these kids, we had them do 4 sub-maximal aerobic fitness tests, which is, unless you really like that sort of thing, it's uncomfortable. They came, they showed up, they did it. Not only did they do it, on average, they had immediate mood improvement. So if you do pre-post mood scales, anxiety scales, everything that was significant went in the direction of feeling better. Which goes a little bit against what I told you about for the exercise study, but this was, in any case, what we found, that they immediately afterwards felt emotional symptoms of improvement. And yet, none of them, on average, the sample did not meaningfully change their exercise rates, and they did not meaningfully improve their aerobic fitness. So the take-home message from this is counseling is not enough. So our next plan is to add to this Prescribed exercise is individualized based on how fit they are, first of all, individualized based on what kind of exercise they like. Some of us love high intensity intervals and couldn't bear the thought of jogging for half an hour. Other people feel the exact opposite. So it will be personalized, and that study is in the planning stage. So just to conclude with a couple of slides about clinical implications, what can we do as clinicians, as people that have family members regarding this heart bipolar link? And my message is that we can mitigate these disparities in treatment for heart disease and outcomes, no matter who we are. So here are the disparities. When it comes to prevention of heart disease, when it comes from attending an emergency department having a heart attack, what happens to you, whether you go for interventional care, whether you get the appropriate post-heart attack prescriptions and follow-up, anything that you can imagine, how long it takes to get an ECG, how long it takes to see the doctor, everything is worse if you have serious mental illness. And this is true in any setting. So it's not just in the US or in Canada or in Scandinavia, everywhere the studies is the same thing. And it's true across conditions, doesn't matter if it's heart disease, diabetes, hypertension. If you're a person whose chart has a psychiatric diagnosis and you're presenting for one of these conditions, you're just not going to get the same level of care. And the tough part to stomach about this is that there have been studies showing that if all you did was take people with bipolar disorder and make sure that they have the same standard of care, preventive and intervention, as people without bipolar disorder, you remove much of the increased risk of heart disease in serious mental illness. So this is not impossible. Just use statins and blood pressure pills and counseling, whatever other people are getting. If you just gave that to people with bipolar and serious mental illness in general, they would do as well as people in general. I think that part of what explains this is the prematurity, is that they're not getting it in part because they're too young to be having these problems. And so this person that said they're 52 and had a massive heart attack and have had at least a decade of, they said a decade, I don't know where that number came from, but I would assume that it's more than that. We have to shift the frame into thinking about this younger in people with serious mental illness. And again, this slide, the purpose of this slide is to say that the idea of integrating physical health into mental health is not a new one. At least a decade of people talking about it. It's really, really important, as we've learned that early mental illness predicts later mental illness, that depression in adulthood predicts dementia. Like, we don't need to have more information about how important it is to mitigate this association, but I would say we're still at the earliest possible stages of integrating cardiovascular health into mental health. So I wanted to close with a couple of messages of hope. Some people ask me, they're like, well, you see teens with bipolar disorder, they have multi-comorbidity, and then they come in and then you're studying them and telling them about their increases of heart disease, risk of heart disease. Like, how does that affect them? I will tell you that people they are concerned about it. They don't like the idea of having early heart disease. Their parents are concerned about it. They generally are appreciative to know about it early. And I will say that most of the people that have at least spoken their minds to me have said that they are glad that we are treating it as something real. And so we have a wall of hope at our clinic where youth that come in write a little message of hope that we display on the wall. And what we found was that without being asked to do this, like, a number of them had this kind of heart theme in it. And as you can see, they're warm and fuzzy messages, but that heart theme comes in. And so I found, at least over the past 10 years, that it does resonate with patients and families. And it's our motto at the Center for Youth Bipolar Disorder is to us, the heart not only represents dedication and care, but it is a symbol that bipolar is linked to cardiovascular risk and affects mind, brain, and body. Final wrap up, youth with bipolar disorder have increased cardiovascular risk for multiple reasons. Cardiovascular metrics of many sorts, genetic, retinal, etc., are associated with psychiatric symptoms, brain structure, and brain function among youth with bipolar disorder already at this young age. And bringing those two together, this heart bipolar link could help us with identifying what's causing bipolar disorder, looking at novel treatment approaches or novel deployment of typical treatment approaches when it comes to heart disease. And also, and I emphasize, reducing stigma, because I still think that there's a lot of people that don't think the illnesses that we treat are actually real. That keeps people from either coming forward or from taking their treatments, or at a minimum, it makes them feel worse about having the illness. So I think that this physical health, mental health connection has a lot of those values. So acknowledging our funders, both philanthropic and federal funding, and the great team at the Center for Youth Bipolar Disorder. And I think we have a good chunk of time for discussion or Q&A from online or in person. Thank you.
So I'm opening for the questions, if anyone has one in the room.
Thank you, Ben. This is fantastic, Dr. Really enjoyed it. Really a lot of clarity now listening to what you've said. I've been having a little question now and then, but really appreciate the extent of connections. You had a very good message of hope, but I was wondering how complex the problem is to treat the risk that you have for these young people with cardiovascular issues. Because a couple of things you said. One is exercise doesn't give them the subjective possibilities straight away after the first attempt to do that. Secondly, there may be atherosclerosis, there may be cardiovascular, microvascular reactivity problems early on. Is exercise going to benefit these folks as much as exercise benefits people who don't have bipolar disorder? In other words, I guess my question is, should we add something more than exercise to really get benefits of it?
Thanks, Lena, for the question. I would say it won't help them as much, it'll help them more. So if you look at, there was an American Heart Association scientific statement on cardiorespiratory fitness. And if there's one metric, if you get to choose one metric to improve that's going to reduce your risk of heart disease, it's aerobic fitness. And the extent to which that's true is greater and greater the worse shape you're in. So I put people with bipolar disorder on average is in the worst shape. So I would say that the relative value to them of heart health is greater. The relative value to them of interventions that optimize heart health is actually greater. In terms of, like what else can we do? So one of the things will be, we have these medications that are used for cardiovascular. I said the cardiovascular risk factors are not the whole story, but they're part of the story. So what the American Heart Association statement on youth was focused on is the idea that for some youth, you screen earlier, you intervene at a lower threshold, even with medication. Now, I'm not there yet. I'm not prescribing statins for patients or blood pressure pills for patients, but I think that's something we need to think about, like, what would it take for that to happen? When would that happen to mitigate the risk on brain? The other thing is, I think it should help reduce people's mixed feelings about treatment for bipolar disorder. So data from adults, I didn't present it here, basically shows observational data. One study looked at cardiovascular mortality as an endpoint. This is work done by Jess Fedorowicz in Ottawa now, but was in Iowa at the time. Looking at the burden of symptoms over time in large cohort studies in relation to heart attacks or heart attack death or cardiovascular death. And collectively, what studies have shown is those people with bipolar who have the greatest persistence and symptom burden over time, they are the ones who end up dying of heart disease. And so I haven't seen studies that say improve depression, reduce heart disease risk, but like it would stand to reason to me that managing those symptoms, superior management of those symptoms could benefit them. So for some of our patients, we give them standard of care treatments and they're still not getting better, but there's a lot of people that are untreated or that are really reluctant to be on treatment because of the risks. And so I think that it's really important to know that if you don't control the emotional aspect of the illness, it will lead to this outcome. Thanks.
So I'll pass on to one question to Zoom and then we can go back to there afterwards. So thank you very much for the very interesting presentation. I was wondering to what extent those associations are specific to bipolar disorder versus shared with other mental disorders.
So it's, I think that the quick answer is that anybody with a brain disease in general is going to be more susceptible to the negative effects of vascular effects on the brain. So Parkinson's, dementia, everything. And so that'll extend even to autism. The issue is where the data is the best. So I think that it's most clear, I think, for schizophrenia, bipolar, depression, someone with bad PTSD. I don't think it's magically about bipolar disorder, but I do think it is about serious mental illness more than mild, moderate mental illness. But we're interested, as I mentioned, maybe the person joined in a little bit late, but we are planning a collaborative study across our sites looking at depression, schizophrenia, and bipolar. And my bet would be that it relates more to the severity of the illness than the name of the illness.
Thank you. Any other questions?
I'm briefly curious in how our clinicians with DBT. You just mentioned that you don't regulate the emotional aspect of the like cardiovascular. So I was wondering if you could like maybe elucidate that.
Yeah, thanks for mentioning that. We have a collaborator in Pittsburgh, Tina Goldstein, who's not a relation of mine, who modified DBT for youth with bipolar disorder. And I was previously at Sunnybrook, and we had 3 research coordinators who were also social workers, and mostly they did research, but sometimes they saw patients. It turns out at CAMH, you can only be one or the other. So I said, okay, we're just going to have DBT studies, and we don't have control groups. So essentially, our DBT studies are looking at what are the mediators and moderators of DBT outcome. What happens when you're done after a year of DBT? Like, because you're not ready to, most people do not finish DBT and walk away, say, thanks very much, nice to know you. They need a bit more. So we have a 1-year extension that has like boosters. And then we have a study looking at stepped care. So you don't have the level of dysregulation or risk behaviors or suicidality that requires like a year of 50 sessions. So can we give you like a 10 milligrams of Prozac version of DBT? And then see if they need to escalate or not. So those are the studies that we have. And about your comment about the heart, I always tell the therapist, I'm like, when we saw from our pilot study that, like the study that the Pittsburgh group did, over time, our therapists, patients had reductions in emotional dysregulations and reductions in suicidal ideation, similar to the other study. It was a dissemination implementation study where you say, okay, we got this like castle of DBT for youth bipolar, but can anybody else pull that rabbit out of the hat? And then they carefully train your site and then see, can they do the same findings? So we did. So I always remind them that, like, it's great. We don't want them in hospital. We don't want them committing suicide, but also I believe what you say to be true. If you see a person in extreme emotional dysregulation, you don't need to ask them how they're feeling. Like, you see it in their cheeks, you see it in their eyes, you see, so there's no way if anyone's had a panic attack, it's like, they're not comfortable, but imagine being like that, like 60% of the time for 20 years. So I do, we plan to study that. Yeah, thanks.
Thanks, Ben. It's good to see you. It's all different. I may have missed bits and pieces at the beginning, but I wanted to ask a little bit, almost in the same spirit as the question about sort of coming across diagnoses. There's this rage, these days, and I'm as guilty as anyone else, about thinking of the second stages, right? So, to what extent has there been data acquired on sort of the risk state, what might be called the net risk state for bipolar disorder, and it's sort of the findings in this regard kind of in a similar direction, or conversely, is it that it's almost built in sort of from so is it progressive, or is it kind of baked into the
Yeah, I mean, it's a fair question. I think I would offer the view of that whole issue of neuroprogression and staging, that it hasn't thrived in bipolar disorder. And part of it is because it's just such an episode. It really isn't dementia, and it really isn't heart disease. It doesn't go in one direction. So you can have someone, like I have a 15-year-old patient currently who I'm going to check my email after this, because her first psychotic mania just will not resolve, been in hospital twice. So she had nothing before, no addiction, no trauma, nothing, 15 years old. So what stage is she in, right? She's like right at the gate, she's at stage 5 or whatever it is. But I hope in a month from now, she'll be at stage 1, right? So I think state trait considerations are especially important in bipolar, like what is mania. And I would say that from the adult data, mania seems to be like at least, if not significantly more biologically perturbed on inflammation, BDNF, oxidative stress level. So I think that symptom polarity matters, symptom severity matters. And then as to whether it builds up over time, I don't know. It's an indirect answer to your question, but we had a polygenic risk score study looking at bipolar polygenic risk scores. And so part of the issue, I don't know if this is really staging, but the diagnostic spectrum, because people often are concerned about what we mean by spectrum. So in the youth that I'm talking about, we have bipolar 1, bipolar 2 by DSM criteria. And then bipolar, we would call it now other specified bipolar and related disorder, which means there's some reason you don't think they have the full version. And typically these are youth that have recurrent 1 to 2 day episodes of hypomania, or they've had hypomania and never had a major depression. Those are our bipolar NOS that we call them. And we don't find major subtype differences clinically in terms of within the limited sample that we have for our polygenic risk scores. This was recently published in JCAP. There was not a subtype difference. So bipolar NOS versus bipolar 1 didn't have a different genetic underpinning.
And with respect to some of the heart rate,
we haven't. Yeah, it's a fair question. I can't remember if we've done it. I don't have it at the top of my head, so I'll say I don't know. Symptomatically, we've looked at it, and it hasn't been a big driver for most things, except for cerebral blood flow, where that definitely is sensitive to mood. Yeah, Martin.
Thanks, Ben, for a great presentation. Just one question about like what you're presenting will be, I mean, this cohort or this group of participants that you've been assessing. Are you planning to have some kind of ultra long-term following up of those young people now as they are really experiencing those coronary problems? So whether using either research assessment or clinical administrative data from ISIS or something.
So I think most people in the room are researchers, at least, and then also maybe clinicians. Is that right? Or students, or mostly? I mean, so in any case, everybody's aware that to get like a 30-year study to follow people is like virtually impossible. And so you have to kind of prepare for alternatives. And the first protocol that I ever wrote in 2009, when I moved to Sunnybrook in the first place, was a registry that was like wide open, and it said like, you give us permission to contact you and reach out and to connect your information to health records. So the answer is, well, we don't have long follow-up. We do have their health information, and we do have like ICES. So like being able to link this to registries, healthcare registries, is one way. Oops. That's one way that we could do it. But another thing is we're hoping to eventually do like a follow-up study where we bring them back in to check their hearts. Those kids that have been like 10, 15 years ago, they saw us initially. And now, like, I keep hearing from therapists that keep following these patients, kids getting married, having kids. And so we're interested in their kids as well. So I'm hopeful, but right now we don't have anything structured, and we're just planning on public databases to link our clinical information to.
Thank you. I think we have time for one last question. There's a question in the room.
I don't know if it's a burning question, but so I think I remember being on the site. There was a site that was sort of showing that there were one was the one that was the most at risk for cardiovascular diseases.
Yeah.
And I was wondering if you think that there's like a specific role of mania in there, that mania maybe would be a greater risk factor for those diseases.
Yeah.
Or it's either sits in early onset.
It's a totally fair question. I mentioned there's like two really good studies that looked at the cardiovascular outcomes. One found depression drove it, one found mania drove it. So I don't think we have enough information to say. But like I was saying to the earlier question, if you look at biomarkers during mania versus depression, they tend to be worst in mania. So if those biomarkers that were in that, oxidative stress inflammation, if they're especially high, then what you're saying would make sense. I think we need more information, but what you're speculating, I would speculate the same.